2 minutes.
Chapter 5.
Yes, you can start. Yes,
Yes.
Okay.
we have more than 120 people on board. Please.
Okay. Good afternoon, my respected FARO colleagues. It is my immense pleasure to welcome you to 14th FARO webinar. Today, the webinar is hosted by Bangladesh Society of Radiation Oncologists, BSRO, and it is organized by BSRO, IROS, and IRORA. I am Dr. Meher Zabib, Assistant Professor, Department of Radiotherapy, Sir Solimullah Medical College Hospital, and Dhaka, Bangladesh. And today I'm here for moderating the session. First, I'm just giving the brief description of the format of the session. At the starting, there will be a greeting speech from FARO and also from BSRO. And there will be a scientific presentation followed by question answer sessions, and there will be some expert opinions given by the panelists. And lastly, there will be a concluding speech provided by Dr. Mayank Parmata. And it is my humble request to the resource persons that as it is a very time-bound session, please maintain your time limits. And without further delay, I would like to request Dr. Rajesh Vasishta, Vice President, the Federation of Asian Organizations for Radiation Oncology, to make the welcome speech on behalf of FARO. Dr.
Good
Vasishta.
evening, good afternoon. And dear office bearers of FARO, faculty members and delegates, I would like to welcome you all on behalf of FARO 14th FARO webinar on total body radiation presented by Bangladesh Society of Radiation Oncology. For members during COVID epidemic to remain academic active and updated in recent advances. The initiation of scientific webinars was taken by Indonesian Society of Radiation Oncology for FARO and legacy was taken forward by Chairman of Scientific Committee by Dr. Mariam Joy of Philippines, then by Anita Boston of Malaysia, now by Dr. Meng of Indonesia. These webinars were well attended and participation growing every month. Not only these academic webinars, FARO has also involved in other academic activity. Thanks FARO for doing us for these. The total body radiation is a specialized technique used as a part of conditioning regimen before stem cell transplantation. Total body irradiation also used as a palliative radiation therapy for symptomatic disseminated bone metastasis. But way is different in palliative setting. May be given as full body in single fraction or divided by in hemibody or lower and upper into fraction. Palliative dosage may range from 4 to 7 gray in single fraction or 2 fraction. We can achieve good palliation by the total body irradiation. I must congratulate Dr. Meng for such excellent webinars under our able chairmanship and wish him good luck for future. I have already seen the presentation of Dr. Tahima Yasmin on total body irradiation, where she has explained very well all about the total body irradiation. Hoping all of you enrich your knowledge by these webinars, and all the best to all. Now I welcome and request Dr. Tomin Yasmin and Dr. Bhattacharya and other panelists to start this session. Thank you.
Thank you very much, Dr. Vasishta. Now, on behalf of the host society, BSRO, I would like to request Professor Kaji Mushtaq Hussain, President of the Bangladesh Society of Radiation Oncologists, to deliver the greetings.
Hello.
Yes, sir.
Dear all, summer greetings and very good afternoon and good evening from Bangladesh. Welcome to today's 14th FARO webinar hosted by Bangladesh Society of Radiation Oncologists, BSRO. As you know, that Bangladesh has started its journey in modern radiotherapy era. Especially, we have started it in non-government hospitals or centers. Our oncologists are trying to cope up with the latest technological advancements, especially the Evercare Hospital Dhaka has started TBI by VMAT planning. Our clinical and radiation oncologists, and Dr. Beshajit Bhattacharya, speaker, Dr. Tohida Yasmin, hemato-oncologist Dr. Abu Jafar Mohammad Saleh, and physicist Dr. Morugana Pasami. They have made a breakthrough in radiation oncology by starting TBI by VMAT in Bangladesh. So I think they deserve a huge clap and a very big thank you. Let us share our experience by the radiation oncology team and the hemato-oncology team from of Evercare Hospital. I hope we will enjoy it. Thank you very much for attending the FARO webinar. Thank you.
Thank you, sir. Thank you very much. Before going to the presentation, I would request Dr. Abu Jafar Mohammad Saleh, Senior Consultant and Coordinator, Hematology and HSCT, Evercare Hospital, Dhaka, Bangladesh, to share his experience. Though he was one of our learned panelists, but he has some time issues. So before the presentation, we are requesting his sharing of experience. Over to you, sir.
Yeah, thank you very much. Thank you, everybody. Actually, it's a great pleasure and honor for me to share my experience at FARO 14. Actually, it's a huge thing for our country, Bangladesh, that we started bone marrow transplant in 2014 at government level. And then allogenic transplant started in 2015. And as a private hospital or private setup, the Evercare Hospital, we took the lead actually. And we started all kinds of bone marrow transplant like autologous, allogenic transplant. And recently, we are doing successfully the haploidentical stem cell transplant. So regarding the bone marrow transplant, we know that TBI or total body irradiation is an important factor for the lymphoid malignancies or lymphoproliferative disorder, or in the myeloid where there is an extramedullary things or involvement is there. So considering this thing, we were stuck because of the TBI, and I must congratulate Murugan and Dr. Vishwajit. They are here. They will tell in details that they took the lead, and they gave me the support and hope to start TBI by VMAT planning, as we heard from the president. So what happened as a clinician and as a first starting, I was really, a little bit worried about my safety and long-term outcome about the TBI for my patients. So we started with an lymphoid malignancy. It was a lymphoma, and the patient was a medical student. So it was very difficult and emotional thing for the patient as well. But the way we started, there was no immediate complication for all the cases. And it was flu TBI. And then another case, we started with flu TBI for a young kid for acute undifferentiated leukemia. And then we started the traditional ALL patient, adult AL, with side TBI, cyclophosphamide TBI. So all the cases, we did not, I'm happy to say that the cooperation and the teamwork we established, it was excellent, especially the transfer of the patients, scheduling for the TBI. Those who are, expert centers, we know that how they arrange. But for us, it was a new thing. So during the conditioning stays, the patient were immunocompromised, and we had to schedule in the early morning. And the technologists, the physicists, and all the staff were very helpful. And none of the patients, they had any immediate complaint, like lethargic, too much lethargic, or vomiting or other things. During the engraftment, some of the two patients, they mentioned about jaw pain and some pain over salivary gland areas. So, and it was very minimal. They did not take that much of analgesic. And regarding nausea and vomiting, none of them had extra nausea or vomiting compared to the medical, conditioning. The traditional conditioning we do by the chemotherapies. So for myself, I want to share that it was a very smooth start, and with negligible complications. And the patient, all patients, they were very compliant, and actually nothing severe or anything serious to mention. So it was for me better than the chemotherapeutic conditioning in other sense. So the starting journey was smooth. We finished initial 3 cases with different conditioning and different diseases. And the patients currently are doing excellent. And so far, the first case already finished a long time, off immunosuppressant, and still now in remission and doing fine. And the second case also, third case also the same. And currently we are preparing another 3 cases for TBI conditioning, and hopefully the journey will continue. And I believe the other hospitals will follow the same experience or the confidence. Actually, it is the confidence and the support. I think from the radiation colleagues, they did an excellent job. In terms of arranging the simulation. And I don't know that much about the TBI, but of course, we know that it's a very difficult and time-consuming procedure. And especially the weak, sick patients, the patient's compliance, their care, conditioning. and everything transfer. So it should be done in a comprehensive, in an organized way between the clinical and the radiation stuff that I think the others can follow this same experience and can proceed on. As the president mentioned that it is the first time in Bangladesh, I think it was a good start. And of course, Evercare Hospital and Dr. Bishwajit and Marugan took the lead, and I think others will follow. And sorry, I am in UK now to visit my family for some emergency issues. So I took the chance, and it is thank you, the organizing committee, to give me the chance to share my experience and earlier before the main session. And I would be happy to answer if any burning questions, or I will be available in mails. If you have any question, any suggestion or comment or opinion, I'll be more than happy to answer online or by personal communication, by phone or anything. So without delaying the others, I want to complete my session here. I mean, my time. Thank you very much. And thank you, FARO, again, for giving me the chance and opportunity. And thank you all. Thank you.
Thank you, sir. Thank you. Thank you for your time. Now we are proceeding to the scientific presentation. Today we have a very dynamic speaker with us. She is Dr. Tawhida Yasmin, Senior Specialist, Department of Radiation Oncology, Cancer Care Center, Evercare Hospital, Dhaka, Bangladesh. And she will talk about her experience, and she will talk on total body radiation for bone marrow transplantation by VMAT planning and initial Bangladesh experience.
Doctor, hello. Hi,
Yeah.
Dr. Meher, can we perhaps before we begin,
Yeah,
we
yeah.
can do
Yes.
a quick photo session
Yeah.
while we have everyone?
Yes, as Dr. Saleh is leaving, yeah, we can have a photograph now, so we can include everyone. Can you please take it, please, Maya?
Dr. Saleh, are you still there?
Here. I'm still here.
Please, camera.
Please start your camera.
And others requesting everybody, assistant.
So the photo will include all the resource persons.
Yes, Professor Vashista, if you could open your video. Hello, Prof. Shrivastava, how are you, sir? Hello, Dr. Imjai.
I'm here. Open the camera.
Prof. Tati also has joined. Okay, Dr. Filbert, if you could.
Hello, hi everybody.
Hello.
Nice to see all of you.
Hello, Tati ma'am.
Hi, Tati.
Okay, Dr. Filbert, you could take the
Imjai.
picture.
Yes, professors and doctors.
I just finished my other meeting, not yet finished, but still break.
Ben is here.
Dr. Ben, yes.
Yes, Ben.
Hello.
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 Hello, Ben. And Mariko and Basista, where are you? Mariko.
Oh, Ben is here. Good.
Yes. Okay, we'll take the picture. Dr. Vashista, please.
Rajesh Vashist is not there.
Yes. Okay, we have everyone.
All right, I will take a picture in the count of 3. Please do stay still for an additional 1 to 2 seconds, just so we can get a clear picture of everyone. 3, 2, 1. One more time. 3, 2, 1. Cheers. All right, thank you very much, professors and doctors.
Thank you. Please, Dr. Mary.
Yeah, thank you. Thank you, Dr. Maya. So we were proceeding towards the scientific presentation, and I request Dr. Tawhida to start her presentation. Dr. Tawhida, please. And to the audience, feel free to submit the questions in the Q&A boxes. And after the presentation, there will be a Q&A session, question answer session, and then the questions will be collected from the Q&A box.
Hello, I hope I am audible.
Yeah, you are. And we can see the screen as well.
Thank you. Thank you, Dr. Meher Javin. Thank you, Dr. Rajesh Vasishtha sir and Professor Kazi Mustaq Hussain sir for your speech and introductory note. Good afternoon, distinguished panelists, fellow colleagues from Bangladesh and abroad who have joined today's event. In next few minutes, I'm going to speak about our early experience of doing total body radiation for transplant candidates. This radiation was done in a conventional Linux setup, which is equipped to treat patients with modern radiotherapy techniques. We have utilized VMAT planning for the irradiation purpose. So total body irradiation is a radiotherapy technique that is utilized as a component of preparative regimen of hematopoietic stem cell transplantation. It is used in conjunction of chemotherapeutic agents. So if we go through the history, just a decade after Röntgen described X-ray, a new radiotherapy technique of therapeutic irradiation of whole body by using 3 simultaneously active low voltage transient ray source was described by a German scientist back in 1905. Later, this method was experimented, improvised by many researchers in many indications such as leukemia, lymphoma, disseminated malignant disease, and other radiosensitive tumor. Up until 1950, when a breakthrough happened in both chemotherapy and radiotherapy. Several chemotherapeutic regimen agents were helping radio-resistant tumor, and megavoltage X-ray high-energy LINAC machine with cobalt-60 cesium-137 had added significant advancement in the effective use of radiation therapy. There was first report of bone marrow infusion in human following low-dose TBI. TBI also got the recognition of immunomodulator after a successful kidney transplant between dizygotic twins. In 1970, Peters et al. Described the superiority of the fractionated TBI regimen in high-dose technique. Until 2005, TBI has been practiced in the classic setup using dedicated setup, extended SST, specialized equipment. Later, modern radiotherapy techniques that has been used for conventional practice was explored and found quite feasible with additional benefit. Helical tomotherapy for TBI and total marrow irradiation was first described in 2005. Intensity modulated total marrow irradiation on conventional LINAC was described in 2008, and VMAT for TBI was first described in 2015 by Chakrabarty et al. TBI helps in conditioning stem cell by providing further cytoreduction to achieve minimal residual disease state prior to transplantation. For ablating hematopoietic stem cells, reduces graft rejection by immunosuppression, also by creating space in bone marrow for donor stem cells. The advantage of TBI in transplant preparative regimen helps in it reaches sanctuary sites like testis and CNS. It can produce dose homogeneity to the whole body regardless of blood supply. It has less chance of cross-resistance with other chemotherapeutic agents. Unlike chemotherapeutic agent, it is not dependent upon excretion or detoxification. More importantly, it has the ability to tailor the dose distribution by shielding specific organ or boosting specific site. So TBI-based regimen is widely used as a part of myeloablative or non-myeloablative conditioning regimen due to its immunosuppressive properties and its effectiveness against most leukemias and lymphomas. Other indication includes multiple myeloma, melanoma, etc. Sometimes TBI is used as in the transplantation from haploidentical donor with immunosuppressive protocol. According to the Center for International Blood and Marrow Transplant Research, plasma cell disorder, non-Hodgkin's lymphoma, and acute myelogenous leukemia has been the leading indication for adult hematological transplantation. For pediatric population, ALL, MLL are the most common indication. In our country perspective, the scenario is almost same for the indication for adult and pediatrics. In our hospital at Evercare, we have done transplant in almost 60 patients till date. All the pediatric patients were leukemia patient. And for adult patient, leukemia, lymphoma, myeloma, myelodysplastic syndrome were the most common indication. What is the benefit of adding TBI with chemo for transplant? There has been randomized studies, meta-analysis, institutional series comparing chemotherapy alone versus TBI chemotherapy in different condition and regimen of AML. Investigator enrolled patients with AML, CML, ALL, multiple myeloma even, and in general, all the investigators of different type in their study found that TBI is an important component of conditioning regimen for ALL and a subgroup of patients with advanced disease. Role of CML is less. TBI-based regimen was found superior in terms of leukemia-free survival, time to relapse, transplant mortality, and overall survival. TBI fractionation and schedule is a component of type of ablation intended, disease status, history of previous treatment like myeloablative or conditioning regimen, history of being treated heavily previously for relapsed or refractory stage, in addition to patient's age, physical condition, and comorbidities. Most common myeloablative TBI dose is 12 to 15 gray over 3 to 5 days. Apart from that, International Lymphoma Radiation Oncology group described different fractionations, of which most commonly 12 gray in 3 days using twice daily 2 gray per fraction is most commonly practiced. Reduced intensity conditioning, which is RIC, is also achieved with using 4 to 8 gray. Conditioning regimen starts from 2 to 4 gray in 1 to 2 fraction. Seattle protocol utilizes single dose 2 gray for non-myeloablative conditioning regimen. Toxicities of TBI. For low-dose TBI, nausea and vomiting has been the most common toxicities. Cataract is the only concern for late toxicities. In case of full-dose TBI, immediate toxicity includes nausea, vomiting, diarrhea, mucositis, parotiditis, erythema, pruritus, etc. Pulmonary toxicity is one of the main late toxicity that influences the treatment planning parameter. In addition, veno-occlusive disease of liver, renal toxicity, endocrine disorder, neurocognitive deficits are important as well. For growing children, learning deficit, growth failure, and multiple endocrine disorder is also reported. Traditionally, TBI is done using conventional LINAC, static APPA field or parallel opposed field arranged in extended SSD, keeping patients in standing or lying position. Photon beam energy ranged between 4 to 24 MB and can be used with tissue compensator to boost region of varying thickness or shield blocks to limit the doses to OR. This long treatment and setup time impacts patient comfort and ability to maintain accurate positioning during the treatment. There is lack of 3D treatment planning data and the requirement for large bunker to accommodate extended SSD and the specialized treatment equipment. For pediatric patients who are under anesthesia is required to be treated with lateral beam, keeping the patient in supine position. Other techniques of TBI include static beam with multiple angle while patient is in one position. Static beam with patient in multiple position. Multiple small field TBI where beam moves over the statically positioned patient. Small field which is static and patient moving horizontally, or swiping beam. So what is the benefit of TBI by doing VMAT? It can be done using a conventional LINAC treatment unit. It has the ability to deliver treatment at SSD, which is similar to the conventional radiotherapy. Better customized dose distribution with better homogeneity throughout the whole body. That is, we can lower the organ dose by blocking previously irradiated field or dose escalation in target structure like in high tumor burden area. Patient can be treated keeping in supine position only and becomes more comfortable and reproducible. And 3D treatment planning data is available. It has increased reduces the need of no additional. It can be sufficient enough to accommodate machine that
receiving that therapy, breast cancer, lung cancer, prostate cancer.
Excuse me, someone's mic is not mute. Yeah, I think you can continue. It's mute now.
It decreases the treatment time. Coming to our process of radiation, I will be describing our process of radiation in upcoming slides. So this process is an interdisciplinary approach where hemato-oncologist, radiation oncologist, medical physicist, and radiation technologists together and plans the TBI process. Documentation of the diagnosis, disease status, prior chemotherapies, recent bone marrow finding, and CSF analysis are documented along with comorbidities. We do the baseline evaluation of lung, hepatic, renal function test. Baseline hematological biochemical analysis is done. For cardiac evaluation, ECG echocardiography is done. Chest X-ray is also done. Thyroid study, ophthalmologic examination, testicular examination, pulmonary function test, dental screening, and baseline viral screening is also done. As a new technique, we have acquired the approval from the appropriate authority. Then after, once the patient is taken for TBI, informed written consent from the patient and family member is taken. The process of treatment planning, the process of total TBI, objective, benefit, complications, toxicities, expected outcome, and alternatives is explained. For male patients, opportunity of sperm banking is also offered. For patient immobilization, a 120-liter Electa blue bag vacuum cushion was prepared that supported patient's whole body. In addition to that, 3-clamp brain thermoplastic mask with appropriate head support is used to immobilize the head. Orphic footrest foot separator is used to immobilize the feet. Later, patient was positioned in head first position initially in the CT simulator, and CT images were acquired from the head to mid-thigh. Slice thickness was 5 mm. Next, the patient is rotated 180 degree with the backlog, keeping the fiducials, reference fiducials in situ, and a second set of data where CT data were acquired from feet first position from the toe to pelvis. Although the CT simulator is capable of taking images of the whole body in one go, but we have acquired 2 CT data set as we cannot treat the patient in one position due to the mechanical limitation of the treatment couch of the LINAC. The acquired 2 CT data sets were transferred to Monaco treatment planning software, where the images were fused and co-registered to produce the whole body. The Bonney landmark and reference fiducials were aided the fusion. Roughly, the whole body is the target PTV. Critical structure contoured including lung, kidneys, liver, lenses. We have contoured few other organs such as eye, parotid gland, heart for the record of the dose. So lung OAR was created by subtracting 3 mm isotropically to ensure that ribs are adequately irradiated. And kidney OAR was created by adding 5 mm isotropically as PRV. PTV of the upper part of the body was created by subtracting lung, kidneys, lenses, and 3 mm from the outer body contour. And PTV of the lower part was 3 mm subtracted outer body contour from the both legs. Upper and lower PTV was over pampered than 4 cm to prevent under and overdose. Uniform outer body contour was ensured to avoid MLC max or any inhibits during optimization. For treatment planning, 2 sets of plan had been produced. In head first position, the body is divided into 4 to 6 sections, each having their own isocenter. Each section was 22 cm with 4 cm overlap. Feet first plan had 2 to 3 isocenter field. For the lowest field, which is the feet, had a wide 3D CRD APPI field and has been that was used to cover adequately. Bias dose technique was used to take care of the overlap between the 2 sets of CT plans, and VMAT QA device used for each arc film for checking the overlaps. Treatment plan evaluation was performed using dose volume histogram. 100% of the prescribed dose to at least 90% of the PTV and 95% of the prescribed dose to at least 95% of the PTV was checked. The mean dose was recorded as well as the hottest dose to the 2cc, D2cc and 5cc was taken as a indicator of maximum dose. Dose homogeneity of the target is evaluated by the ratio of the dose received by the 90% of the volume of the minimum dose and received by the hottest 10% of the volume. The mean dose value were used to assess the dose to the organ at risk. This table on the right side showing dosimetric description of the one patient who was prescribed 12-gray radiation in 6 fraction in 3 days. We were able to achieve the planned parameter and homogeneity index, which is around 1, and mean OR dose was less than 8 to 10 gray. For QA check, we used IBM matrix for patient-specific QA. We compared the treatment planning system fluence with the measure one. Analysis of the gamma passing criteria with 3 mm DTA distance to agreement. Sometimes large area VMAT takes TBI, sometimes the large area of VMAT like TBI, 4 mm DTA is also acceptable. For us, 3 mm DTA for brain ISO, we got 99.5%. For lung, this pass rate, we got 97.1%. And for kidney, we got 96.4%, which means for all, we got above 95% pass rate. Being a JCI accredited hospital for 5 times in a row, our hospital had already an existing process of infection control, which facilitated our infection control policy and processes. We transported the patient in a clean and sterilized bed or wheelchair. We allocated special lift for the morning and evening treatment. And there was thorough deep cleaning and scrubbing of the mold room and CT simulation before the procedure, and treatment room and corridor for every treatment. All the technologists who were directly involved in the process used PPE, and we have scheduled the patient as a first patient in the morning after complete sterilization. 6 hours later, again after disinfection, patient was taken for the second fraction of radiation as the last patient. The interval between the 2 fractions per day was minimum 6 hours. Irradiation was performed at a photon energy of 6 MV. The proximal segments of the head and upper pelvis of the patient was treated in head first supine position. Then the patient was rotated 180 degrees to irradiate the feet first position. Before radiation, the position of the patient was verified using KVCT matching for both bony and soft tissue reference. In all patients, positional accuracy was 2 mm, plus minus 2 mm. The challenge was the arm and feet that took 2 to 3 attempts for reproducing. Our total treatment time was 1 to 1.5 hours, including positioning and imaging. This duration was reduced subsequently when the team was more acquainted with the new techniques. So total treatment time expended for each TBI process was like, for immobilization, it took around 2 hours, CT simulation approximately 1 hour, co-registration and contouring took 3 to 4 hours, and planning evaluation took 2 to 3 days. For QA check, it took 2 to 3 hours, and treatment time per exposure was 1 to 1.5 hours. This duration was reduced subsequently again when the team was more acquainted with the new technique. I want to tell what challenges we faced. The large PTV required multiple overlapping treatment arcs. So hot and cold spot within the PTV and in the junction had to be taken care. Creating a uniform dose distribution utilizing VMAT technique in a irregular field like PTV whole body was the big challenge. Reproducing the setup of hand and feet took multiple attempts, and time to VMAT TBI is still high. This is the patient's demographic and follow-up of the 5 patients we have treated till date. Out of till date, we have treated 5 patients starting from 2020 and 2021. Out of them, 2 were pediatric patients, 3 were adult patients. Both pediatric patients were leukemia patients. Rest adult patients were a case of ALL and mediastinal B-cell lymphoma. All the patients were either high-risk disease or incomplete remission 1 or relapse state. One of them failed second-line salvage therapy. The patient with B-cell lymphoma received myoconditioning regimen in Seattle protocol, and rest of the patient was planned for myeloablation followed by hematological stem cell transplantation. Of them, 3 were given reduced intensity conditioning. 3 to 5 days after TBI, the stem cell transplantation was done. They were hospitalized in a dedicated BMT unit. Nausea, fatigue, erythema, pruritus, and mucositis was the most common observed acute toxicity in a grade of mild. All of them were discharged after successful engraftment. 3 patients are on regular follow-up and living a disease-free life with no reported late toxicity till date. 2 of the patients died due to disease after 1 year and 6 months of post-transplant due to refractory disease. A quick scan of the published literature that supported the feasibility of the VMAT TBI. Shantanam Chakraborty et al. In 2015 from India described that VMAT TBI is feasible for the first time. They planned 12 gray with 8 gray mean dose to the lung. Andreas Springer et al. In 2016 published their feasibility of VMAT TBI in 7 patients. They utilize a dose ranging from 12 to 13.2 gray in fractionation with a mean limiting dose to lung 10 gray. They mentioned the couch time being 1.5 to 2 hours. Christy Simons et al. In 2017 in their article of VMAT TBI feasibility study using Pinnacle TPS and Electa Agility, LINAC reinforced the practicality of VMAT TBI. Finally, Kadir et al. In their Turkish study published VMAT TBI in pediatric patients. They treated 22 patients with 12 gray. Mean lung dose achieved was approximately 7 gray. They found the process was feasible. So in conclusion, TBI in VMAT technique enables faster and uniform radiation delivery throughout the irregular large PTV. Appropriate patient selection is a critical component. Better organ sparing and dose modulation. Treatment can be given in a setup of modern liner with no additional equipment. It provides better patient comfort, reproducibility with 3D dose information. It is now accessible and affordable. Till now, 5 patients were treated. We have got encouraging results in terms of acute toxicities and successful engraftment. Long-term follow-up is needed to understand the outcome and late toxicities. First of all, I want to thank you, Bangladesh Society of Radiation Oncology, BSRO, and FARO for giving us the opportunity to share our Bangladesh experience in their esteemed platform. It feels uplifting when we get to share our experience. I want to thank the administration and all the stakeholders of Evercare Hospital for helping in every way and making the BMT and radiation oncology team successful. Thanking to BMT team who had been doing hematological stem cell transplantation for last more than 6 years and maintaining an international standard. Not the least, my team, Radiation Oncology, who worked day and night to make this procedure successful. Thank you for your attention. Thank you for your patience hearing. Thank you.
Thank you very much, Dr. Tawhida, for your very interesting and informative presentation. I can see that Dr. Srivastava and Dr. Tati have joined. Thank you, sir, for joining. And the session is now open for any question and answer. And in the question Q&A box, we have 3 questions waiting for you. The first one asked by Yong GC, and he asks, do you find difficulties in the overlapping when summing up the plans? And how do you verify the junction dose during the treatment?
Shall I?
Yeah, sure.
Shall I?
Yeah, sure.
So actually, when we treat these kind of larger fields, the junction matching is a challenging one. Actually, when you look into the technique, the upper part involves 4 to 5 isocenters. So each isocenter is almost 22 centimeter apart, where we are giving 4 centimeter of overlap. So when we do the 4 or 6 isocenter in one single operation, the VMAT operation algorithm will take care of the overlapping between the 2 arcs. So, but the challenge here is when we are shifting the patient from head first to the feet first. So when we were evaluating this, so we did expose the film by instead of the patient, we have kept the solid water phantom and we have kept the flints to check the overlapping. So as we are looking in the overlapping, we doesn't need something like a scanning software and all. By just a visual inspection, we can understand whether it is overlapping and all. So initial evaluation was very positive and we didn't get much of overlapping. So this needs a rigorous practice. Even in the initial 1 or 2 patients, we have challenges which we took a long time. For example, initially we were doing the simulation itself, we took a long time because this needs a close cooperation between the technologists and medical physicists and radiation oncologists. So each of them has to explore to their maximum. So that's how we can do it.
Thank you, Dr. Appasamy. I think we have many other questions also for you. The next one is from Knowledge and Stanso, and it is, do you do a PSQA for all ISO center, and how do you do for the FS that exceed the detector electronic part?
I'm not getting the question.
Yeah, the question says
PSQA and
PSQA, yes. Do you do a PSQA for all ISO centers?
Definitely, because it involves almost one arc. So each arc we can perform the QA separately. Because as Dr. Toida was showing, we used to do all 6 to 7 arcs in 7 QAs. So and we will match with the plant data. So it is what we do for everything. For example, we have shown 3 arcs here, but we do for all.
Okay.
And we have got very interesting passing rate as well.
And I have a question from Dr. Arman Reza Choudhury. Probably this is for Dr. Tawhida. Practically in your 5 patients, had you faced any immediate toxicities?
Thank you for the question. For all the 5, not all, 2-3 of them had nausea, fatigue, erythema, pruritus, and mucositis, which was very mild and symptomatically managed.
Then next question is from Pungapen Tangbuduanzit. Do you concern about the dose rate? Do we need to use the lowest dose rate?
Actually,
Yes,
it is not.
absolutely.
Actually, it is not, because see, when we go think about the conventional, the SSD will be at the extended SSD. So, but where here we are doing 3-dimensional conformal treatment plan. So actually, we could be able to see how much dose is going inside the patient body in the like any other conformal radiotherapy. So actually speaking, the dose rate may not have a biggest impact because we are giving the almost 2 gray. So will not have a biggest impact. In fact, the VMAT dose rate of 600 centigrade per minute helps us to reduce the treatment time significantly.
Yeah, we have another 2 questions in the QA box. I think we can take up to this and no more as we have some time constraint. The next question is from Noor Iziana Binti Mohsin, and she asks, how do you perform in vivo dosimetry for VMAT technique?
So actually, there are many ways of doing in vivo dosimetry. For example, we can use some kind of MOSFET to verify the patient dose. So, but we have not yet performed anything, but it is in our future plan. So we are planning to evaluate it completely.
And the last one, last question we are taking is from G. Ing, and he asks, besides from the lung and kidneys as where, will you consider heart as where? And what is your dose constant for heart? Are you able to achieve the constant dose for lens, Tmax 10 gray? 3 questions.
Yeah, I think I will answer the last question. Yeah, we could be able to achieve the dose less than 10 gray, even I think less than 6 gray. I think Dr. Toida was shown the distribution. Yes. But rest of the question, I think Dr. Toida has to answer.
Thank you for the question, G. Actually, as we are still getting started with the procedure, and we were actually going through the published literature, what they are doing, what outer world is following. So till date, although we have started, we did the baseline cardiac evaluation on all our patients were fit. None of them are having any cardiac comorbidities, but for 10 gray in 12 gray in multiple fractionation for heart, we are not following any constraint, but we do look at as low as reasonably achievable. Thank you.
Thank you. That's all for the question answer session. Yeah. So we are going forward, and now this is the time for the expert opinions from our very learned panelists. And we have already we have learned so many things from Dr. Appasamy in the QA sessions, and we were waiting for learning more. But first, I am requesting Dr. Bishwajit Bhattacharjee, Senior Consultant, Radiation and Clinical Oncology, Evercare Hospital, Dhaka, Bangladesh, for delivering his expert opinion. Dr. Bhattacharjee.
Thank you, Meher Javin. And I'm very much grateful to the FARO and other allied organizations to give us the opportunity to share our experience. The thing is that before me, one of our panelists, Dr. Saleh, has told his experience with our TBI output and everything. But I'm not telling about any theoretical thing, but I just want to share some my experiences as a radiation oncologist, how we managed to do it, and what were the challenges we faced. So just little things. So I think that might help some of our colleagues to start this service. Initially, actually, you know, there is a very complicated procedure and it is not very much well practiced in all over the world. Very few places are doing wherever the bone marrow transplant facility is available. And that conventional technique is the gold standard, we know all, but still then we have gone through the literatures when we got request from our hematology department. Considering that patients benefit and the request from our hematological department, actually, I was dared to do that. I must say that I was dared to do that. And before that, as a preparation, I studied for all the literatures for about 1 month and studied that these papers I shared with my specialist, Dr. Tawhida, who is the key person in the whole procedure, and also Dr. Murugan as well. Then I discussed with my colleague, Dr. Saleh, and discussed about our limitations, our skills, knowledges, and experience and everything. So I took the decision to go for TBI because as we are experienced in VMAT planning for more than 15, 16 years. And basically to me is that TBI is nothing but a complicated and composite VMAT plan. So I found the main challenge is the physics. The physics is very important thing. So what are the things are that to match the arc fields? That is very challenging, I found. So I was very much aware to see the dose overlaps or any underdose, and also to see the lung dose, kidney dose, because there is, we found in the literature that what were the organometrics that we have to be very strict to save from radiation. And you know that we all in our learning curve at the very best, but we have to proceed. We have to serve our patient. And considering all these things, so we started, and we started like in 2020 September. We have given the first patient that was for conditioning, and fortunately we have not faced any difficulties just managing the acute toxicities, and they are very mild. So after doing one case after another, we were a little bit brave to do these things, and day by day we could modify our processes, and this time shortening was there. So nowadays, after 2 years, now we have formed our own protocol. So I think this is the experiences I can share with you. So I think that VMAT planning is a very good tool to do the TBI, because we can see the doses and in terms of dose homogeneity and where doses, and almost all centers in the world maximum centers may be running with one LINAC like ours in the corporate setting. So if we dedicate one patient for the VMAT, so how it with our patients? So considering all these issues, and we have a very good bone marrow transplant service, we started, and I hope we'll go further, and we have to wait for a long, maybe few more years to see the late delayed effects. So that I cannot comment now. But I'm very much hopeful, and my team is excellent team in terms of that physicists, radiation technologists, they are the key persons, because whatever we have done, that is on the hand of our technologists, and physicists is the game maker. And also we have to have a very good communication with the hematology department, because we have to discuss everything in every step to make a consensus. So we did it. So I think we have tried our best, whatever we did, and in the near future we are planning to do in a regular basis. And another thing, that we are very much careful and cautious to select the patients. So actually our hematology colleague, he decides, and actually he gives the demand that what he needs, either conditioning or ablation. So accordingly, nowadays we are planning to do the TBI in future. Thank you very much. And I must thank you, Dr. Tauhida, for his excellent presentation. And thank you, everybody. Thank you so much.
Thank you, Dr. Bhattacharya. It is an initial step in Bangladesh, and it takes a lot of effort to take the first step. Thank you for your effort, and also your sharing the experience. And now we are going forward to the next panel of experts. I request Dr. Miriam Joy Calaguas, member, Bone Marrow Transplant Team, St. Lucas Medical Center, Philippines Radiation Oncology Society. Ma'am, over to you. Please make an expert comment.
Thank you, Dr. Meher. Good day to everyone, and thank you to FARO and BISRO for organizing this webinar, for the invitation to participate today. My name is Dr. Miriam Calaguas, and I did my training in TBI at the Fred Hutchinson Center, Swedish Hospital in Seattle, Washington, not too long ago. I am currently practicing in 2 radiation oncology facilities in the Philippines that perform TBI as part of our cell transplant conditioning regimen. We started doing TBI in the year 2007 after our variant LINAC 23EX and Siemens artists were commissioned, and we have treated a total of 59 patients since. We initially treated most patients with high-dose TBI, part of a myeloablative conditioning regimen. This consisted of 12 to 15 gray, given in 8 to 12 fractions over 4 days with 2 to 3 treatments daily. Earlier, during this time in bone marrow transplantation, the regimen that we used for TBI was 10 fractions in 3.5 days. So that means bringing down the patient 3 times a day for a small 1.2 gray. However, in recent years, we have shifted to doing more low-dose TBI as part of a non-myeloablative conditioning regimen, which consists of 2 gray delivered in a single fraction before the stem cell transplant. That's just 1 day before. At present, we utilize a conventional TBI technique using a clinical setup with parallel opposed right and left lateral beams, with the patient supine on a custom evacuated vacuum cushion. The dose is prescribed to the midpoint at the level of the umbilicus. We use an extended SST setup of 360 to 400 cms using 6 MV photon beams. We use in vivo dosimeters to maintain whole dose homogeneity to less than plus to minus 10%. We also use a beam spoiler to deliver adequate doses to the superficial skin. Since we now perform low-dose TBI almost exclusively, we do not utilize lung or kidney blocks. Having said this, I'd like to thank our speaker for an excellent lecture for sharing her experience with TBI using VMAT for ARC-based therapy. This is definitely an interesting development that we should explore more, given the wider availability of VMAT-capable machines. Our speaker has extensively outlined the feasibility and reliability of this emerging technology. She has clearly explained the advantages of using VMAT-based TBI, including the potential for better dose homogeneity and conformality, high precision in patient positioning and dose delivery, and less toxicity for specific OARs and patient comfort. Ultimately, we still need further studies which will clarify whether these dosimetric advantages translates to clinical meaningful outcomes. Both the institutions where I practice have VMAT-capable LINACs, and we are now increasingly using VMAT for head and neck, lung, CNS, gynecologic, and urologic tumors. It is encouraging to hear from our speaker about its promising role in the radiotherapeutic management of hematologic malignancies as well, particularly in TBI. Admittedly, my experience so far had been limited to conventional TBI, but we have been encouraged by this webinar to explore the feasibility of VMAT-based TBI in our institution. Through these kinds of activities, we are able to learn from each other's experiences in using these novel technologies, and we hope for more educational collaborations which will allow our physicists and radiation oncologists to maximize the available technologies when performing TBI. Thank you.
Thank you, Dr. Kalagos. Thank you very much. Now I request Dr. Hidenobu Tachibana, medical physicist, section of Radiation Safety and Quality Assurance, National Cancer Center Hospital East, Japanese Society for Radiation Oncology. Please, sir, make your comments.
Okay, thank you very much for your introductions. And good afternoon, everyone. My name is Hidenobu Tachibana, head of medical physics in National Cancer Center Hospital East. And I've heard of Dr. Yasumi's presentation carefully because our institution still uses conventional technique. And okay, and I have a comments and for the VMAT TBI. There are some concerns for VMAT TBI from physics views. One is dose rate. The other is dose volume constraint in planning. And the other one is the patient-specific QAs. As long as I know, irradiated MEU was determined by Excel worksheet in conventional TBI. Still common in Japan. Because the history of the TBI is very long in Japan. So historically, dose distribution in patient body was not evaluated. Thus, how do oncologists and medical physicists evaluate dose distribution of VMAT TBI, which is visualizes? So currently, our institution uses treatment planning system to determine the MU, and we can see the dose distribution. However, our oncologists show anxiety of how they evaluate it. It is difficult to evaluate the dose distribution visually. And in conventional TBI, dose rate of 50 centigrade per minute in common, that is much smaller than usual dose of 300, 600 centigrade per minute for VMAT TBI. The dose rate of conventional VMAT is determined from the care of the lung dose. I think not, I'm an oncologist, I'm a medical physicist, but our oncologist told me that the most important OAR is the lung dose. So we there's a research, and we try to perform the treatment planning for the VMAT TBI. At that time, radiation oncologists have told me that we have to take care of the lung dose. So, it should be difficult to determine the dose rate in the VMAT TBI. But from the Dr. Yasmin presentation, the higher dose rate would be safe because you show the VMAT TBI is a good result currently. So more future, I strongly believe that the dose rate would not be care. Dose rate, any dose rate would be good. And for physicists, to change the subject, for physicists, and after treatment planning, we must perform the efficiency verification measurement of the VMAT TBI plans. But Dr. Apasamy shows a very simple verification measurement. That's good. Thank you very much. And as you know, the Japanese physicists, Japanese people is, as you know, workaholic. So Japanese people do the much measurement for the TBI because the TBI covers the whole body. So we have to cover the 100 cm. That's too long. Too much effort would be needed. So, but Dr. Apasamy shows simple diode measurement. I will introduce your methodology to Japanese people. Thank you very much. And in the treatment planning, I don't know the dose volume constraint in the optimization. How much should we spare the lung and the other important OIR dose? It is difficult because there's no patient data. And the target is the whole body, including lung and kidney. So we should not reduce those lung and kidney. So there's a trade-off. I can control the dose, lung and the kidney, but I should not reduce the dose of the lung and the kidney. So we have to research. We have to do the research for the OIR, optimized OIR dose. And okay, in our institute, I use the conventional technique, but I perform the in vivo dosimetry using the film. I created some small pieces of the film, and I attach the film to the patient body, and then we measure it. So the result is very good. The accuracy of the film is good, and the agreement between the treatment planning and the film is good. So the methodology is low cost and very efficiency methodology. And finally, I think the history of the TBI as well as VMAT TBI has just started. TBI using treatment planning. And so but VMAT is a promising technique for TBI. However, we should start the TBI VMAT carefully. Thank you very much for your questions.
Thank you, Dr. Tachibana, for a very valuable comment. Now, our last panel of experts, Dr. Murugan Apasamy, Head of Medical Physics, Radiation Oncology, Evercare Hospital, Dhaka, Bangladesh. Sir, please enlighten us with your valuable comment.
First of all, I would like to thank FARO for giving the opportunity for our entire team to share our initial experience. So, and thank you for organizers also for gathering such a huge crowd. I think almost 183 participants now. So, which shows that many people are very much interested on this topic. So, the credit goes to our entire team as well as our oncology department. So, as far as the medical physics point of view, as Dr. Hebron was saying, the conventional technique was the standard one. But if you look into the conventional technique for something like a private hospital for us to start with, we have certain limitations. We should have a large room, and we should have a beam spoiler, and we should have a in vivo dosimetry. It has some. We have to purchase something newly. So when we was looking, when Dr. Bishwar came to me first and said we want to do some kind of TBI for oncology patients. So we did a complete research on literature survey and everything. And we had a discussion with the vendors, and we had a special session with the Turkish people where they were doing the VMAT planning from 2015 onwards. I think many of them know Bora Das, who is now the head of Electra Unity, the physics head of Electra Unity, MRI based LINAC. So his team was very well known for doing TBI based on the VMAT technique. So we had a special session remotely with him. And for first few patients, even he joined us remotely and evaluated our plan. So I'm taking this opportunity to thank Bora Das team to helping us to implement this technique in our clinic. So as far as physics point of view, yes, as Dr. Toida mentioned, as Dr. Hebron said, in TBI VMAT, we use the maximum field sizes because our conventionally in IMRT or VMAT, we will be treating very small areas with heterogeneous dose. So where the MLC can move and make some heterogeneous dose. But here we are looking on the other way. I want to treat large area, but uniform dose. At the same time, Dr. Bishwar and Toida want to spare the lung also. So that is the biggest challenge. And with the help of VMAT, and we could be able to do it. And not only us, many part of the world, they have started. There are many number of papers. You can go to the PubMed. There are many papers are publishing. We are also in the process of publishing our results, initial experience. So there are a number of centers started. The biggest catching point is here you can use the existing machine, as Dr. Ida pointed out. It can be performed with the normal treatment distance SSD. And moreover, as Dr. Hebron said, we can see the dose distribution. And still many questions are open. As one of the audience is asked what is the optimal dose rate. So what is the impact of the dose rate? And we are giving we are doing a trade-off between the organ saving and giving dose to the entire body. So these are all the new options has evolved in the VMAT technique, which is not available in the conventional technique. In the conventional technique, we only give standard dose, and that also calculated based on some manual calculation or some measurements. So this VMAT based planning gives us an opportunity to see the distribution, what is going on inside the patient. So that is the only confidence we are going with this technique. And when you consider any radiotherapy institution can start this procedure. So these are all the two advantages, and we have started our journey and almost last 2 years back. Still now we have got very good results. So and in future we are trying to expand it with the conventional technique as well. We are in the process of establishing conventional TBA. And we are also in the process of establishing the patient in vivo dosimetry for all VMAT patients. Hope this presentation or experience will help inspire many people in Bangladesh. I think across they can start with it. So as a take-home message, what I would like to tell to the audience is the VMAT-based TBI is very much possible. Only thing is the entire team need to be get oriented, and they should be able to understand what is the limitation of the equipment and what is needed for the clinician. So with this well understood team, the VMAT can be performed hassle-free. Thank you.
Thank you very much, Dr. Murugan Appasamy. Yes, indeed, the total team effort, your work is very inspiring to all of us, and all the best for the conventional approach of TBI as well. And we are nearly at the end of the session. And for concluding speech, I would like to invite Dr. Mayang Parmata, radiation oncologist, Department of Radiation Oncology, Dr. Sipto Mangunkusumo, National General Hospital, Faculty of Medicine, Universities Indonesia, Jakarta, Indonesia. Dr. Mayang, please conclude the session with your concluding speech.
Okay, thank you very much, Dr. Marizamin. So good evening, everyone. Very honored to be joined by everyone here from all FARO countries and other colleagues too. So congratulations to the Bangladesh team of BSRO under the leadership of Professor Kazi for a successful webinar with the topic of TBI today. And also thank you to Dr. Said from BSRO serving in the FARO ETC, Education Training Committee, who has done the coordination and preparation for this event. Thank you, Doctor. So this is a very interesting topic, and I'm sure it's very beneficial to all our FARO members everywhere. And we could see from the many questions from the floor. And I hope that the communication line could remain open, and maybe some participants still have questions. They could reach out to the Bangladesh team, to Dr. Tauhida, if you don't mind, of course. Yes, and Dr. Appasamy and all the team, please. And so thank you for the participations and your expertise, Dr. Tauhida as a speaker, Dr. Meher as a moderator, and the respected panelists all have given very valuable presence and insights with all the participants. Thank you so much. And we really appreciate the continued full support from the FARO officers represented by Dr. Vashista here greeted us today. And of course, all the respected FARO advisory boards and also the Secretariat, thank you. And lastly, last but not least, thank you to all the IROS and Aurora team under the leadership of Professor Tati. It's always a pleasure to be serving with all the solid team. And thank you for all participants. We hope that you will continue to join us in the coming months. We will have the FARO webinar every month, and we look forward to welcoming you again each month. And with that, we conclude today's webinar. Thank you very much. Thank you. See you. Thank you, Dr. Meher.
Okay.
Thank you, Dr. Meher.
Thank you, Prof. Kazi,
Thank you,
everyone.
thank you, thank you, everyone. Thank you, thank you.
Thank you.
Thank you, everyone. Bye.
Bye.
Bye, Prof.
4 years.
Bye.
Bye.
Bye. Hi, Miriam.
Bye, Kasi.
Thank you, Dr.
How are
Miriam.
you? Nice to see you.
Ayan.
Nice to see
Bye.
you, everyone. Thank you very much.
Bye. Thank you, Dr.
Thank you.
Bye.
Bye-bye.
Bye, Dr.
Tomo,
Tamaki.
bye. Tomo,
Thank you. Nice to see you all.
Vashista is here. Yeah, bye.
Hi, Tomo. Hi, Ben. Si Ben.
Hello. Excellent session. Thank you very much. Bye.
Oh, God,